Fantastic. So good afternoon, everyone. Thank you very much for taking your Thursday lunchtime to join us on this webinar. So my name is Cassie Forbes, and I'm the Programme Operations Manager at the Primary Care Development Team at the RCGP. So I'm just going to go through some brief housekeeping before we start the webinar, and then I'm going to take you through the agenda. So you will have joined as a panelist. I'm sure we're all very comfortable with Zoom already, but just to understand what the differences between host and panelist are, you've joined without video, and you are also muted. So I just want to take you through how we're going to be fielding questions throughout today. So if you could please put questions related to the programme using the Q&A function. Please don't put the questions in the chat because the speakers will not be monitoring the chat, and we will field questions at the end of the webinar. If you have any clinical questions, they often take us time to reflect, go back and talk to CQC. Please put them in the survey that we will post at the end of the webinar. We will have time to answer a couple of questions about PCD at the end of the webinar. So I'm going to take you through the background to PCD and why we thought it was relevant to make a specific webinar about maintain your rating. Then Helene Irvine and Ellie Fowler are going to take us through how you can maintain your current rating in your practice. Vic Gaffney, our relationship manager, is going to talk you through a little bit more about the support that we offer in the primary care development programme. We have the Q&A section that I mentioned, and then we have some closing points that will be relevant for you. So the primary care development programme was originally started back in 2016 as a project between NHS England and the RCGP, originally set up to support practices and special measures. The pilot was a great success, and following the end of the pilot, RCGP chose to continue on with the project without the assistance of NHS England. So the way in which it works is we have a team of expert advisors based throughout England and Wales that go in and support a practice either in advance of or as a result of a CQC inspection. And we've also started work in Wales in the last 2 years as well. So the project is extremely busy. In 2021, we started support for 26 practices based throughout England and Wales, and we have the current practices that we carried over from the 2020 year as well. So there's a lot to do, and we're constantly reviewing what's going on with CQC and adapting our processes and procedures as a result of what they are following. So here's a little bit about our impact. Since 2019, 98% of practices that we have supported have either maintained their good rating or improved their CQC rating. And 96% of practices in special measures have exited special measures following our support. And we're also really pleased to say in the last couple of days that we have made the finals of the BMJ QI Quality Improvement Team of the Year. The finals for that are next week, and we're really excited to see what that outcome is. But that was a collaborative project that we did with Birmingham and Solihull CCG, and we're really pleased to see that our programme's been rewarded in such a way. So why did we set up Maintain Your Rating? Well, we did an evaluation of the programme back in April, and we realised that 73%, so effectively 3 in 4 practices that had been rated good previously, were then placed in, were placed in special measures. So that shows that often a practice, 3/4 of the time, will go from a good rating to special measures. That is something that the practice will be often blindsided by. They perhaps will have assumed that because they had a good rating previously, that can carry over. It might also have been a number of years since their previous inspection. So then they might not be aware of how CQC has evolved in this time period. So we were aware that there were a lot of practices who felt very destabilized by going from a good rating to it being placed in special measures. And we wanted to set up a service that addressed that and supported practices. We also were originally a special measures project, so often there's the preconception that we only support practices in special measures. This webinar and some of the comms that we're doing is to show that we support practices no matter what your rating is, to ensure that you continue to receive a good or outstanding rating in the future. So that's a little bit of background about PCD, and I'm now going to pass you on to Helene and Ellie, who are going to talk a little bit more about how you can maintain your current rating.
Thank you, Cassie. Welcome everyone, and as Cassie said, thank you for joining us today. My name is Helene Irvine. I'm one of the Deputy Clinical Leads on this programme. I'm going to start by providing a general update on the CQC's recent inspection process. We have a video recording from one of our RCGP GP advisors reflecting on the experience of a recent inspection. And Ellie will provide more detailed information from a practice perspective, actually what happens on the day on the ground. And then our colleague Vic will talk about our offer of support in helping you to maintain your CQC ratings. I would strongly recommend that everyone keeps an eye on the CQC Mythbusters pages, as they are updated on a regular basis, and quite a few of them have been updated recently. Thank you, Cassie. Next slide, please. So what's new? Well, in June this year, the CQC announced they were making changes to the monitoring process. What they wanted to do was to assure the public that the care they're receiving is safe, with a big emphasis on quality and minimisation of risk. The approach is built on learning from the CQC's transitional monitoring approach and the emergency framework. And they will continue to monitor services in three main areas: monitoring risk and becoming more targeted in their activity, bringing information together in one place for inspection teams, presented in a way that supports inspectors with their decision-making, and testing how they want to work in the future, including how to provide a more up-to-date view of risk for people who actually use the services. The key changes to practice are that the CQC will undertake monthly monitoring of practice data and create a risk banding. Inspectors will be making monthly checks of practices within their own portfolio to ensure the risk bandings are accurate. The practice ratings will not change. What we want to do is ensure practices that they will not be asked to submit monthly data. However, if the CQC identify any risk, they may contact practices to seek assurances, and this is always what they've done historically. People's voice and experiences of care remain central to their approach, and it tells them about the quality or safety of services. I just wanted to very quickly talk about whistleblowing, because apparently in 2020, during the COVID crisis, 50% of CQC's physical inspections were informed by whistleblowers, which I think demonstrates the CQC is taking whistleblowing disclosures very seriously. It's probably a good time for practices to reflect on issues relating to whistleblowing in their organisation. And obviously, it's better if a member of staff if they have a concern, they raise this within their organisation, and obviously able to do this in an open and no blame culture. It's therefore essential to ensure that practices have whistleblowing policy in place and it's shared with staff. Next slide, please, Cassie. So what can practices expect? Well, the information included in the monitoring process includes any ratings and breaches, the time since the last CQC inspection, any changes in registration, for example, a registered manager or location, information CQC may have received, including patient experiences, any whistleblowing, safeguarding alerts, and also information received from stakeholders such as the CCG, LMC, and Healthwatch, etc. And obviously, published data available, which will include QOF, patients' experiences, how practice is managing long-term conditions, prescribing safety, and obviously any issues around patients' access. The inspectors will be reviewing information about the practices using a software app that utilises an algorithm to create a risk banding. And in the past, for example, the CQC's transitional approach to monitoring, they used over 100 data items to give a calibrated view across the metrics, including QOF, GP patient surveys, prescribing, staffing levels, childhood immunisations, cervical smear targets, CQC data, and obviously demographic data. If there is no indication there's a need to reassess ratings due to any evidence of potential risk, the CQC will publish a statement on the practice's profile page on their website to inform the public and people who use the services that a review has been undertaken and there are no concerns at this time. And this will be referred to as low risk. As I said, the practice ratings at this stage will not change. Practices will be contacted by email prior to this being made public on their web pages. In cases where the information review indicates that the CQC may need to reassess a rating of the quality of care, the inspectors may want to gather more information, and these are deemed as higher risk. This will include a call with a provider, and this is called a direct monitoring activity. For services where the CQC believe people may be at increased risk of poor quality care, they may undertake an immediate on-site inspection, and this can occur at any time. Next slide, please. So we're just going to cover some of the top tips really about how you can prepare. The CQC appears to be focusing very much on safe and well-led, but this does not mean that they're not assessing all the other CLOEs. We all know that CQC inspection can be stressful and challenging, and it's really important to delegate. It's not just any one person, particularly the practice manager, ensuring that the practice is meeting the criteria for this CQC inspection. I think it's also important to give people time to undertake some of the tasks and to get everyone involved. It is a whole practice effort. Ensure that the staff are aware of what will take place during the inspection, and often sharing some typical questions that will be asked can help them in the preparation. The CQC will want to see evidence, amongst others, of training updates, immunisation of status of staff. They're really, really hot on this. Also DBS. We've noticed, I work for an LMC, and we've noticed we have an increase in reviews of DBS in the last 2 weeks, which seems to be related to an acceleration of CQC's inspections. Also competency and capabilities of staff, and the practices are undertaking audit and reflecting on their activity. We know that currently there are enough current pressures facing practices at the moment, and CQC inspections, are just a nail in the coffin, I suppose, for some. But all this can take time to collate the information. Everyone has a role, and the sooner you are prepared, then obviously the easier the process. Next slide, please. So what does SAFE look like? Well, I just wanted to pick up really on infection control as a good example. So the new National Standards of Cleanliness came in April 2021. It sort of came underneath the radar, really. And if any of you looked at the document, it's very secondary care focused, but primary care is actually mentioned. In fact, it first comes up in page 9. I want to reassure people that the CQC have said that they do not expect practices to display posters of their ratings of how they match up to the standards of cleanliness. There are some useful information in the document, for example, about audits. It is a very long document, but it is worth reflecting on to see what parts of it that you can pick up which are relevant to general practice. I want to ensure practices that you will be meeting if not all of the requirements within the document, so please don't get phrased by it. The other thing is mandatory training. Obviously, ensure staff are trained and competent to take their role, and you can provide evidence of this. As I said before, they're really, really hot on immunisations of staff, and this is particularly so, obviously, now moving into the mandatory status for those staff going into care homes. Prescribing, this is a really, really hot topic. They're delving deep into this, and we're going to pick up on this in more detail later. And also supervision and safeguarding, again, we'll expand on this. And significant events. Everybody knows the importance of the sharing of learning and how this is shared both in and outside of the organisation, and also the general health and safety, so fire, Legionella, safe staffing levels, etc., etc. So in most circumstances, the assessment or review will be undertaken remotely by the CQC General GP SPA and with consent from the practice, and Ellie, as I say, will expand on this later. The number of patient records that to be reviewed from search depends on the size of the population and how well the practice is performing. If the practice is not to be monitoring medicines in line with guidance, more evidence will be required to demonstrate this, and they're likely to access more records. Inspectors reviewing information, as I said before, using algorithm. And in the past, the CQC's transitional approach to monitoring, they used over 100 data items to give a calibrated view across the metrics. They're looking at how effectively the practice monitors patients on high-risk drugs, for example, and ensure that they are looking at how the results are processed, the diagnosis, and if there are any adverse effects. And they're reviewing prescribing more generally, including obviously medication reviews, over and under prescribing. And identification of patients who've had not conditions appropriately diagnosed. Also, how practices are responding to MHRA, CAS, and drug safety alerts, and how these are cascaded to staff and what changes have been made as a result. The more prepared practices are in undertaking their own searches will ensure that national and local guidelines are followed, with the emphasis on providing quality of care and obviously safety to patients. The CCG med optimization teams can help practices with searches, and as part of our support, we can provide very great in-depth details on the type of searches that will be undertaken. They have certainly picked up on a number of practices where there has been misdiagnosis, particularly obviously around diabetes and cancer. They will look at how the diagnosis was managed and missed, what processes should have been in place, what was the level of risk and outcome, and what changes have been made as a result to ensure that mitigates any future risk. Next slide, please. So safeguarding, again, you won't be surprised to know they want to know that all staff are up to date with the appropriate levels of safeguarding training. They want to see how safeguarding concerns are managed and escalated to the relevant agencies and within the practice, and any examples of how you report safeguarding concerns. And also, does the practice have registers and how these are updated, how they're reconciled with local authorities' data, and how patients' registers are reviewed. They want to check that staff know who the safeguarding lead is, who attends meeting, and also when the meetings have been attended, is this documented in the patient's records, and the appropriate use of recodes. And what happens when the child becomes of an adult age or when taken off formal child protection plan? Is there still a possibility of safeguarding concerns? And this has been looked at. When it comes to DNA CPRs, you can see they look at least 5 patient records in each of these searches. They may do more. But for DNA CPR, for example, they'll review 5 records in the last 2 years. And they will look at who made the decision, when and the location this decision took place, what the decision was based on to make sure there's no discriminatory factors, for example, the mental health capacity at the time, and if the discussion was recorded and who was present, and a review date. The CQC's national report in March found worrying variation, actually, in people's experiences of do not attempt CPR and their decisions during the pandemic. And while there were examples of good practice, the CQC heard from people who were not properly involved in decisions, who were unaware that an important decision about their care had been made. And you can obviously look at the report and look for it in more detail and recommendations. A number of practices being picked up in the area of the management of long-term conditions, with staff not being qualified, misdiagnosis. For example, one practice, a nurse was referred to the NMC for inappropriate management of a patient who was a diabetic. And interestingly, what came out of that was, although she was put on the register, the practice were actually given quite a damning report, because the nurse had gone to the practice to say that she didn't feel she had adequate training to undertake the diabetic review, and the practice declined to put her on any further training. So I think that's really, really important. And also long-term conditions, it's not just diabetes and asthma and COPD. You also need to consider, for example, dementia, ischemic heart disease, and the management of lower limb ulcers and wound care. It's really important, as I say, to ensure people involved in the care are competent, they're trained, familiar with local and national guidelines, and there's policies in place, obviously, to ensure that people with long-term conditions have appropriate follow-up. When it comes to care plans, they're likely to assess patients' records to ensure a comprehensive review has been completed, including how consent was obtained, what was discussed with the patient and family member or carer, and documentation of the process, particularly in the following groups of patients: so learning disabilities, mental health, dementia, long-term conditions, and palliative care. And obviously, as a practice and clinicians, do you adopt a personalised care approach? It's also important to ensure that care plans are shared with the individual patient, including agencies or families members, and when and who the review takes place, and to ensure that all staff are familiar with GILIC competencies and the Fraser guidelines. Next slide, please. So, as I say, they were looking at 5 patient records, and when it comes to management of workflow, they're looking particularly, obviously, with COVID and the impact of COVID, how pathology results and correspondence is managed, and they want to see evidence they are processed safely, efficiently, and effectively, and who reviews the results and when, and obviously what action or process are in place to ensure abnormal results are acted upon. They want to see that referrals are appropriate, that referral letter contains adequate and relevant information, and the person who's been referred is followed up appropriately, especially if they DNA an appointment, and that the person making the referral is competent and working within their scope of practice. There's a lot of information available to staff on the quality of record keeping and consultation, but they certainly want to see evidence that an adequate patient history has been taken and documented, especially if any red flags have been identified and that appropriate action was taken. There's a comprehensive record of a diagnosis and appropriate examination, and recorded with concise findings and a management plan in place, and documentation of any investigations, for example, referral, and verbal and written information shared with the patient or family, and any safety netting advice and a process for follow-up. Again, staff are trained and competent and work within their scope of practice, and all prescribers prescribe appropriately, including over and or under prescribing, and again, refer to national guidelines and up to date with the BNF or on online access. And the staff are auditing and reflecting on the care they're providing and obviously involving patients in their care. And clinical staff, do they follow guidelines? Do you have enough suitable staff to meet the population needs of your practice? And what plans are in place to cover annual leave, emergencies, staff absences or sickness? And also to ensure all staff are registered with a relevant professional organisation and that the registration is up to date. For example, for nurses, there's the NMC, the GMC for doctors, and the Healthcare Professional Council for the allied health professionals, particularly now important when there are a lot more ARS roles coming into practice. And also, are they trained and competent and working within their scope of practice up to date? So if they are working at advanced level of practice, what does that mean? And are they actually have the competencies to work at this level? And appropriate DBS in place, and obviously, and very importantly, what supervision, especially for non-medical prescribers. Thank you. Next slide, please. So what about leadership and what does good leadership look like? Well, there is certainly a strong, there's a collaboration is emerging as strong leadership, and collaboration is crucial than ever to delivering good care. And certainly good leadership is reflected in ratings for those practices rated as good or outstanding, and poor leadership in those rated as inadequate or RI. It's important that the practice obviously has a robust leadership, management and governance structure in place with clear lines of responsibility and accountability. What they want to see is that the practice of providing quality care based on national and local guidelines. There's genuine engagement with staff, and there's a positive correlation between positive staff feedback and CQC ratings, and addressing obviously staff numbers and skill mix. And staff having the ability to be able to raise concerns without the fear of retribution and having respect for colleagues, and this obviously fits into the overall culture of the practice. Again, staff capability and competencies, and regular supervision, and good communication within the practice between all members of staff and with service users in terms of providing information and responding to concerns and complaints. Obviously, patient access is important, and we all know at the press at the moment, there's some very, very negative press around having access and seeing patients face to face, which does not reflect what's actually happening in the real world. And to ensure that all staff are treating with patients with compassion, dignity, kindness, and respect. They're looking for evidence of continuous improvement and changes that have been made, and sharing examples of progress with others in and outside of the practice. They want to see evidence of meetings with other health and social care providers, including obviously district nurses, mental health, health visitors, midwives, and palliative care, and registers of carers and a cancer register. And also obviously within governance, who's the IG lead, how information is shared, and staff have access to policies and procedures, and these are kept up to date. Chloe's, don't forget all the other things, obviously, that come in, which is about effective and caring and the different population groups, and what evidence and examples you have that you can prescribe that you are doing all this. We have been informed that the CQC are aware of the pressures the GP practices are under, and we do keep reminding them of that. COVID, however, is not viewed as an excuse for not addressing issues related to safety of patients and reduction in the quality of care. And regardless of the pressures created by COVID, practices, we know, are making every effort to maintain high standards of care. On the positive note, preparing for a CQC inspection encourages us all to reflect on what we're doing well, and this is really important to share with the CQC. I think practices often underestimate how innovative they are and how good the care is that they're provided. Don't assume every other practice is doing the same as you and working in the same way. Certainly, there's a big emphasis on collaborative working with other agencies and certainly engaging service users. And I'm sure you can all draw on practices who can provide excellent examples of some innovative projects and new ways of working. And Ellie will cover this later in the presentation. Thank you all for listening. We are here to help. We have an awful lot of information on our website. And if you have any questions, as Cassie says, then please put them in the Q&A box and we will respond to those. And now over to Ellie. Thank you.
Hi, Cassie. Are you showing a video of Elka next?
Yeah, I can do. Let me just stop
Thank you.
sharing the PowerPoint and go on to the video.
Hi, everybody. This is just a very quick reflection from me, reflecting on a practice that I've recently been supporting remotely. So I've been supporting as the GP advisor fully remotely with Jen, who has done a few practice visits, but otherwise supporting remotely as well. So just in terms of the experience, I have to say probably two key things. One is that the experience wholly depends on the IT familiarity and the IT experience and ability of the receiving practice. So this particular practice had a practice manager who was very IT savvy, had everybody focused in on one Zoom meeting, one camera, everybody in one room, was able to facilitate breakout rooms, etc. But I have to say, have previously experienced supporting a practice remotely where it was totally the opposite. Lots and lots of IT issues getting on, audio, video, multiple rooms, etc. So I think in terms of that remote experience, really important to consider the practice that you are supporting and whether they do have the IT know-how as such to be able to support remote advice, because some of that really does involve probing notes, loads of screen sharing data, which can be located in various places on the practice IT system. So does need somebody to be sort of quite rapidly responsive and able to maneuver around their own IT system. So that's one really, really key thing that I would suggest making sure happens right at the outset of setting up remote meetings, is that there is somebody who's got the sort of competence, capacity, capability to do all the IT orientation. The second thing I think to reflect on is actually the information that's presented, I have to say, and being able to see things on screen is absolutely fine compared to being able to see things in person. It does take longer though, so to navigate through various records or various documents does take longer when you're asking the person on the other end to show you the next page or to move to another screen, because you're not in control of that process yourself when working remotely. So I again would say just a reminder that it does take that bit longer to look at things together remotely. And then I think probably the final and third thing to say about the remote experience is really just that sense of connectivity, and always really important, isn't it, to sort of feel really connected with the practice in order to be sort of fully supportive. And again, I think this is fully doable remotely for sure, but again just takes time to make sure that everybody in the space gets a chance to speak. That we found often that meetings can get overtaken by one or two people and other people sort of sitting a bit more quietly, so again important to just make sure that there's space for everybody to be involved in meetings. Voices aren't crowding over each other. It's much more easy to control that space when you're face to face, because you've got natural body gestures that are seen, I think, and communication is much easier. But remotely, I think, again, it just needs a little bit of charge and control to just sometimes take charge of those meetings and make sure that everybody's had an opportunity to have a say and contribute as well. So those are probably just three very simple reflections. I personally have enjoyed the remote experience. Works very well. I think it's practical. I think it's efficient. And I think hopefully sort of practice on the receiving end have had the same experience as well. But I certainly feel that it's a place that you can really get pretty connected with practice to. It's a place where you can look at records and information and data relatively easily as well. And just really depends on having an IT receptive practice at the other end. So hope that's helpful. Have a lovely day, everybody. Bye then.
Brilliant. So just for some context, everyone, that was Dr. Alka Patel, who is a GP that supports us on our primary care development program, and she is a coach as well with us. So she has a lot of experience supporting practices remotely. So that was her experience supporting practices through our program on a remote basis. I believe it's over to you, Ellie.
Yeah, my go now. Thank you.
Thanks.
So that was great from Alka and Helene. So thank you very much, both of you. So I'm going to talk a little bit about what happens when CQC arrives. So these observations are made based on talking to practices who have recently gone through CQC. So sort of going through the new style CQC inspection. What I must state is though that these were practices who were already in special measures prior to the COVID pandemic taking place. So it's possibly in a slightly different situation to what you are now, but I still think it's probably a good sort of learning as to how their experiences were, because I think this will be reflective as to what's going to be going forward. So as normal, as you've had before, the telephone call from the inspector about two weeks in notice to say that they're coming. But what might be slightly different this time is that actually you're often asked now to send information to the inspector in advance. So, and more information than you would have been originally. So things like, and I've got a list of things to show you that to send, so that emailing information in advance. They will arrange for remote searches on your clinical system. So this is a difference to what we used to. They will have a GP advisor who will actually go into your clinical system. They won't access any patient records, but they do have, that does mean that they have a free reign basically on your system without you being able to necessarily see what they're going to be seeing. So we'll talk about what they look at and what searches that they place on your system, and we'll come to those and I'll tell you about a bit more detail about those in a bit. They arrange for telephone calls or Zoom calls with key members of staff. So with a practice manager, with the nursing team, the lead GPs, a member of your PPG. So and so they do that remotely. So again, that's when Dr. Alka was talking about making sure that you are up to date with your how you use Zoom or Teams, and having that familiarity, and those people who are going to have those conversations can share documents. And they also arrange for a short face-to-face visit as well. So it's a big process. Can we go for the next slide, please? Thank you. Lovely. So this is sort of an example of some of the information that might be asked to be sent in advance. So it's the sort of stuff that, as if you were a practice manager, you would have sat with the inspector in the past, and they would have asked you, can you show me the recruitment policy? Can you show me health and risk assessment? In this time now, to reduce, I think, that face-to-face time that they are asking for things in advance. So that's sort of an idea. They'll also want to see your remote consultation policy, which might be something new, performance policies and clinical audits. Again, it's still 2 clinical audits as it was before. Complaints policy, your summary and your actions, patient survey action plans, particularly if you had a recent GP patient survey, have you had an action plan based on the back of that? Also your business development plans, clinical government plans, MDT meetings, quality improvement programs, all things that you would expect to talk to the inspector about, but you're just sending them in advance. Next slide, please. So these are the online calls that are set up. So obviously you get to choose who you're going to have the calls, who are going to have the calls with the inspector, but they are going to be your key members of staff. So they are going to be your practice manager, your nurse lead, or someone who's going to be talking about infection control, your senior GP partner, member of reception, and member of your patient reference group is probably going to be some of the, at least these number of people. So feedback from the practices that I've spoken to that these have been quite robust. And I think it might be partly what Alka was talking about it does take a bit longer to be able to share documents and show information, but that goes into lots and lots of detail. So you need to be prepared, and those people who are on the call maybe do a trial run, make sure that they are aware of what they might be asked about. So practice. Again, practice sharing documentation on screen. Can you show policies, procedures, action plans? And then sometimes it can be, well, I can't just find this right now. Please, can I send it to you later? That's fine. People have said that the inspectors have been very approachable, and that's all been fine. They've been very reasonable about the fact that things are different, but some preparation is needed there, and be prepared for it to be quite challenging. Next slide. So there are now face-to-face as well, and they've said that they want to have limited time, more like half a day, but actually it seems to take longer. I don't know whether this is an experience because practices are in special measures, so it has taken longer. I'm not sure, but it does seem to take quite a long time. Inspectors have asked to review patient notes within the clinical system in a lot of detail whilst they're face-to-face, which seems to be different approach to previously. And as Helene mentioned earlier, feedback from one practice in particular I spoke to said that COVID-19 wasn't considered to be a good reason to not have completed something. And if anything, it was almost a trigger. So just be aware of that when you're thinking about what you may be saying. Next slide, please. So I'm going to start talking a little bit about what outstanding looks like now. We have we actually had a look. So there's a challenging routine. It's about being outstanding. About being outstanding. About what sort of areas have you done that really are above and beyond what normal looks like. And these are the things that you would be talking about at your presentation in advance. What has your practice done that you're really proud of? And you're going to be thinking about things that you're doing that are outside routine quality of care, amazing quality improvement activities you've done. What have you done working with other agencies and providers, which is outstanding compared to other people? How have you improved patient engagement within your practice and collaborative working? And what evidence have you got to show that you've done this? But again, you can really talk about this and sell yourself of any of your outstanding areas at the beginning of your inspection. You can have the next slide. So I had a rummage around in the CQC, on the CQC site to find outstanding practices and to find what they considered areas of outstanding practice to be. And that they really are things that feel a little bit different to the normal day-to-day. So I won't read them to you, but this is a list of some of the ones that I found. But I would also say that to you as well, that obviously you've got the opportunity to go and look at the CQC site and see what's in there. So if you're outstanding now and you want to be staying outstanding, perhaps again have a look at some examples of what's going on. Or another way of looking at it is you could also go onto the site and look which practices have recently gone into requires improvement or special measures. What areas were they pulled up on? Look at their evidence packs there. And are you doing all of those things as well? So it could just be a good trigger there for you to sort of have a way to sort of see what areas are being inspected now. And as Helene said earlier, Nigel's surgery on the CQC site is really good place to go. So there's some great stuff on there. So do keep up to date with that, because there's quite recently there's been a few more updates on there. So there are obviously areas they're going to be looking into. So do have a look at that resource as well. Next page, please. So here are some links as well that about different support for outstanding if you were looking into that. So obviously this is being recorded, so we'll be able to get those links at a later date. So, but there is help out there, is what we're trying to say. If there's something that you're looking at, you can find stuff for getting to outstanding or even very good, if that's where you're aiming at. So next slide, please. I think I'm handing over to Vic now. There we go. Thank you very much.
Thanks.
Thank you. I think it is me, isn't it, Cassie?
Yeah, it is. I have another slide for you as well. Would you like me to move on to that one?
Please. Thank you. Hi, everybody. My name's Victoria Gaffney. I'm the Relationship Manager for Primary Care Development. I think I just want to share some background information with you about about the work that we've been providing since around 2014 that Cassie mentioned earlier. So the Department of Health commissioned the college to undertake the National Peer Programme. Between 2014 and 2017, we worked with 138 practices, of which 118 exited special measures. And as Cassie referred to, there was clear evidence that beyond the reach of the peer programme, there was a real need for support for practices. And so the practice support team at the RCGP was born, later renamed Primary Care Development. And we've since been providing comprehensive tailored support for practices and, of course, a natural progression across PCNs to assist practices and PCNs embed that sustainable quality improvements. It's delivered by a national team of 70 plus advisors, a mix of GPs, practice managers and nurses, with 1 or 2 pharmacists dotted across the country. And it's headed up by a medical director who's supported by 4 deputy clinical leads, of which Helene and Ellie are 2 of our 4. The support that we have provided is wide and varied, from struggling and underperforming practices helping them exit special measures or to improve their RI rating, to helping practices prepare for their CQC inspection. We're able to facilitate meetings, develop away days, address workforce issues, undertake workforce analysis, assess and optimise workforce skills to help increase capacity, embedding, recruiting and helping embed new roles, working around leadership, culture change. So it's really very broad and very wide. Of course, I must speak about the Maintain Your Rating, which is our newest service that we've developed. And this includes a series of remote sessions. So initially we'll undertake a scoping meeting with practice leads, and there'll be some time dedicated to exploring your clinical areas of need and your non-clinical areas. And then what those discussions and what's identified during your scoping meetings then help inform the following remote sessions. And then following your remote sessions, throughout those remote sessions, there's a theme, and you're continually asked, how can you prove it? Can you prove it? How do you prove it? And then that remote offer might be 3 or 4 sessions of Maintain Your Rating sessions, following which you'll receive a summary report of what you then need to be doing to make those changes. Or to prepare for your CQC inspection. Our services are very broad and very wide. They're all tailored to needs. It can be a blended mix of face-to-face and or remote. I think there was a question in the chat about the costs of the service. That really does depend on the needs. So my role is to have conversations with commissioners or GPs or CCGs or PCNs, identify what it is that's needed. You agree, and then what we can do is we build a bespoke offer to meet the needs. So that's how it works. So if it is that you're interested in a particular area of work, even if it's something that I've not mentioned, do get in touch, because if you're from a practice, if you manage a practice, if you're from a PCN or a CCG, if you're looking for support to make improvements, any QI or quality insurance pieces of work, then please do get in touch. We're using our expertise and the infrastructure and the reputation of the college, of course, then we'll do our very best to help.
Brilliant, thank you, Vic.
That's all right.
That's really useful. So there's been actually a lot of discussion going on in the chat and the Q&A. So what I think would be best for us to do, because we sometimes don't have all the answers immediately, and it's great to see that there's been so much discussion. So what I'm going to suggest to Ellie and Helene is that we compile all the clinical questions and we produce a separate document that we can publish alongside the webinar if we're able to answer those questions. What do you think? Does that sound okay?
That sounds great. Thank you.
Great. So I've got a couple of questions about accessing recording. I'm going to address that in the next slide. I'm just going to have a quick scan through the Q&A box and see if there's anything I can address as well in this section. So most of the questions seem to be clinical. So again, as I said, we'll compile it and we'll share it with the recording of the webinar as well. So on to the final points. So I just want to mention about the recording of this webinar. It's not very interesting, but effectively, because the RCGP website is being upgraded, there is a content freeze going on, meaning that you cannot add or take away anything on the website at the moment, while the IT team effectively copy the old website onto the new website. So that means that the website freeze ends on the 4th of October, and as soon as it ends, we will put the webinar recording online and share the document with you. I think I've seen a couple of notes about slides as well. That's absolutely no problem. We'd be happy to share the slides as an attachment as well. So I'm aware that we still have a couple more minutes left, which would be a great opportunity for you to use the full hour that we took from you when we sent the calendar appointment. And we'd really appreciate it if you took the time to complete a short survey. We tend to run a webinar, I'd say, once every 9 months or so, but we'd be really interested, especially since we've had such a great attendance in this webinar, to find out what further information you'd like from us, how we did, and how we can contact you in the future. So we have a monthly PCD newsletter I'm going to pop the link for that in the chat, or you can go to rcgp.org.uk/PCD, which is our website. You click on resources and there's a link for you to sign up. So that tends to go out on the second Wednesday of the month. But just be aware that if you join towards the end of the calendar month, you may not receive the newsletter for the following month. So we put lots of useful information in that about what's going on in our programme, any other useful QI resources, things that are going on with the research team. We have lots of links to other teams in the college. So Vic has provided her details on the previous slide, but if you do want to get in touch using a generic email address, you can do so with pcd@rcgp.org.uk. Vic's number is there, and then there's also a make inquiry form on the website as well. So once you go on to the PCD website, there's a link where you can click in and you can give your name, your CCG, any information that you require. It sends a form through to Vic and then she can contact you to find a little bit more about what your query exactly is. So I'm just going to stop sharing now so I can pop the links in the chat for everyone. And I believe that you're going to get 10 minutes back from your time. So I'd really appreciate it if you could take the time to do the survey. And then we can still maybe 5 minutes of time. Right, so I've just posted the link in the chat, and I'll also put our website in as well, just so people have that information. Great. So that's the survey and the website link, and there's also a form on there, lots of other contact details too. So thank you very much again for joining us on this Thursday afternoon. Thank you very much to Ellie and Helene and Vic for joining me, and have a wonderful rest of your day.
Thank you, everyone. All the best.
Thank you, everyone.
Bye-bye.
Bye.